Real Food for Fertility is your ultimate guide to optimizing your nutritional stores before pregnancy. In Real Food for Fertility, my co-author Lily Nichols and I argue that a healthy menstrual cycle sets the stage for optimal fertility and a healthy pregnancy. You can read the first chapter for free over at realfoodforfertility.com. And did you know that you can listen to Real Food for Fertility for free when you sign up for a 30-day trial with Audible? Head over to fertilityfriday.com/realfood, one word, for details. That's fertilityfriday.com/realfood. Now let's go ahead and jump into today's episode. This is the Fertility Friday podcast, episode number 568. I'm excited to share today's episode with you because in today's episode, I have one of our past guests, Dr. Marguerite Duane, who is the founder of Facts. I'll share her bio with you and information in a minute. But what I'm excited about is that we actually touch on a topic that we weren't necessarily planning on, something that's really important and we haven't really touched on formally in the podcast before. And we ended up spending the first half of our call talking about research, and not just research in the general sense, but the process of getting research to be approved. And Marguerite talks about some of her challenges, even though she's a medical doctor, getting research that she has done actually published in specific journals. And we talk about some of the politics behind that. And although I feel like I'm quite familiar with a lot of that because I just, spend so much of my time diving into research studies, and I feel like I have a good understanding of that world. When I talked about it with our fan practitioners, so, I had a call, one of our regular calls shortly after this interview, a lot of our practitioners were really surprised and a bit shocked to discover what kind of politics really go on behind the scenes. So this is a big part of today's episode. I think you're really going to enjoy that, especially if you have questions, if you're curious. And what's interesting is that as somebody who shares a lot of research publicly, sometimes people come for me. It doesn't happen all the time, but there's the occasional trolling scenario where someone will come at me and, you're choosing this study that has a small sample size and where's the rest of the data and blah, 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 blah. And we really get into some of the challenges behind that. I mean, sure, you can come for me and criticize the quality of the study. I often give that and share that when I'm doing the FAM research series. I'll discuss often some of the limitations with the studies. There's no study that's perfect. But what's interesting is that there are some compelling studies that show some really concerning results that do have smaller sample sizes. But what we don't often see is the follow-up study. And we have to think about why that is. If there's a study that's highly critical of hormonal contraceptives showing a really negative result, so for example, the study with a small sample size showing that 100% of the participants had clitoral shrinkage to an average of 20%. That's one of the scary studies that I've shared in my books and on the podcast. So if you have a study like that, is there a benefit to the drug companies who fund the research to do a follow-up with 2,000 women to show that 2,000 of them have this negative result? Probably not. And so I think sometimes when we're being highly critical and nitpicky and we have to look at also the bigger picture and ask the bigger questions of why don't we have research in this area? Or why don't we have more research about this particular thing? And so really excited to share that aspect of it. Now, the reason that Dr. Duane came on the show was to actually share about some of the recent research on miscarriage and to talk a little bit more about some ways that could be presented. So we do get to that main topic towards the latter half of the episode. So both topics are really important. And I just wanted to share a little bit about that because, like I said, being in the midst of research, I feel like it was a really interesting direction that just organically happened. And like I said, I'm really excited to share that with you. So before we jump in, I'll just share a little bit about Dr. Marguerite Duane if you are not familiar with her work. She is a board-certified family physician. She is the co-founder and executive director of Facts About Fertility, which stands for the Fertility Awareness Collaborative to Teach the Science. It is an organization dedicated to educating medical professionals and students about the scientific evidence supporting fertility awareness-based methods. She also serves as an adjunct associate professor at Georgetown and Dickensian University, hopefully I said that correctly, where she is the director of the Center of Fertility Awareness Education and Research. Dr. Duane cares for patients via her own direct primary care house calls-based practice, MD for Life, in the Washington, D.C. area. Dr. Duane has a unique skill set in the area and field of fertility awareness, as she is trained in multiple modalities, including Cretin, Fem, Neo-Fertility, and Teen Star. She received her MD degree from the State University of New York at Stony Brook and completed her family medicine residency at Lancaster General Hospital in Pennsylvania. Dr. Duane is married to fellow family physician Dr. Kenneth Lynn, and they are delighted to be the parents of 4 children. So without further ado, let's go ahead and jump into today's latest episode with Dr. Duane. And I'm so excited to be back again with Dr. Marguerite Duane. Welcome back to the show.
Thanks, Lisa. Delighted to be with you again.
Well, it's always a pleasure to talk to you. We were talking in the pre-chat. I had to hit record or we would have just talked for the whole day. It was really nice to catch up. But one thing I wanted to start with, would you share a little bit about what you're working on now for anybody who is not as familiar with your work, and any updates that you have around what you've been working on in FACS as well, which is the Fertility Awareness Collaborative to Teach the Science. So for any longtime listeners, may already be familiar with you because you've been a guest on the show many times. And I often, when I talk about FACS, it's like, this is the thing that when all of these women learn about fertility awareness, they get all frustrated and they're like, every woman needs to know. And like, why don't the doctors tell me? It's like, well, Marguerite's working on this for you.
Exactly. And I know I've shared my own personal story that I graduated from medical school and was a doctor that didn't know anything about female cycle tracking, cervical mucus, basal body temperature. It's not something that's taught in traditional medical education, whether it's medical schools, nursing schools, even midwifery schools. Many programs do not include basic education on the value of female cycle tracking and the use of fertility awareness-based methods. And so as you know, that's what inspired me to start Facts About Fertility. We were originally the Fertility Appreciation Collaborative to Teach the Science when we first formed under the FMEC. But in terms of some exciting updates, because Facts has been growing so much, it started out with this elective at Georgetown, conferences in the Northeast. We've expanded our reach not only across the United States, but in Canada, South America, Australia, Europe. We're reaching medical professionals from around the world, educating them about the science underlying the female cycle. And so in 2023, we officially separated from our parent organization and formed our own nonprofit, Facts About Fertility. So that's been a major shift, but it's really allowed us to expand our programming. Not only are we teaching medical school electives, but now we're doing resident electives, we're doing conferences in person and virtual, and we're seeing the impact. I mean, when I first started this work, there were maybe a few hundred doctors that were trained and knowledgeable about these methods. Like in the United States and Canada, that's not a lot of medical professionals. And yet, in the last decade, we have trained over 1,000 medical and nursing students have taken our elective to learn about all of the evidence-based natural methods and really the important role they play in reproductive health care, which is it's so important because doctors are the number one rate-limiting step. We are the biggest barrier to the widespread adoption of fertility awareness-based methods because many doctors simply don't know. And I'm sure many of your listeners have had experiences where they've gone to the doctor and been dismissed when they shared their chart or tried to bring up, some changes in their cervical mucus. So it's really important, the work that we're doing. And we couldn't do it without the support of our donors and, just the support of our friends and colleagues like you who help us to share the facts about fertility.
Mm-hmm. And what I love about your approach too, it's a different world because you are a medical doctor. You're in the world of you are affiliated with the Duquesne University, and all the other universities you mentioned, the work that you're doing within the academic sphere. So what I really appreciate about your work is obviously how academic it is. And I also sometimes wonder when you sleep. Because whenever I'm digging into research, your name pops up all the time. You've published or been on a team to publish a wide variety of papers within the last several years. I don't know if you want to talk a little bit about about that process because like I said, you're doing a lot to legitimize fertility awareness within the academic and medical sphere.
Yeah, thanks so much. Yeah, I will say it always surprises me when people say, like, oh, you publish so much. I'm like, really? Because I feel like I have a stack of papers that are like written, ready to go, mostly written, need to be finalized, written, submitted, and rejected multiple times. So I will be honest, like the research process is a very, very frustrating process. I'm trained in family medicine and our focus is really on clinical care, but I recognized in this field as I was teaching doctors and residents and students about fertility awareness-based methods that we need more research. And so I did something crazy during the pandemic. I thought, for my midlife crisis, it would be a great idea to move my family of six from Washington, D.C. to Salt Lake City, Utah in the summer of 2020. If y'all remember what was happening then. But I moved to Salt Lake City, Utah to do a research fellowship under the direction of Dr. Joe Stanford, who has really been an incredible role model and a mentor to me. And, I look at him and Dr. Richard Faring, Dr. Pilar Vigil, Dr. Mike Manhart, Dr. Hannah Klaus is like the leading researchers that I really aspire to be like. But that fellowship was really an incredible opportunity for me to fully understand the research process. And my husband is also a family physician and an academics and an editor with the American Family Physician Journal. So he writes and publishes a lot. And, when I get these rejection letters or, not even the rejection letter, but we're not even interested. Don't even send the paper because we don't want to consider. I'm like, it's so frustrating. But many people around me encourage me to keep going and to keep pushing forward. And that's really helped. And I realize it is so important. Like we need the science out there because women need access to this information. And so that's why I did have the crazy idea during the pandemic to do a 2-year research fellowship. And I'm so grateful for it. But there are still so many papers. Like we did a paper on the patient experience talking with their doctors about their use of fertility awareness-based methods. And one of the most interesting findings from that study was that a third of patients said that they were laughed at, mocked, or ridiculed by their medical professional for their use of fertility awareness-based methods. And I'm like, that's unconscionable. I mean, as a doctor, there are many things that my patients do that I don't necessarily agree with. I'm sure there are things that I do that my doctor doesn't agree with, like not sleeping a whole lot, but we need to work with and try and understand our patients. So that's a paper I would still love to get published. And I just want to put this out there now because I think this is super exciting. And I didn't even tell this to you in the pre-chat, Lisa. So here's a news flash. My colleague, my mentor, Dr. Joe Stanford, with the team at the International Institute of Restorative Reproductive Medicine, as of Sunday, February 2nd, launched a new journal on restorative reproductive medicine to get more of this research published. And it's so important. And like I said, I'm so grateful to Joe, the opportunity to do the research fellowship. And honestly, what I decided to do my research on at that time, what the topic that drew me in was the topic of miscarriage. And how can we identify modifiable risk factors of miscarriage? Because it's such a common condition. And so, yeah, research is so important.
Well, I definitely want to dive into the miscarriage topic. One thing I wanted to say, though, I really appreciate you sharing just that little tiny window into the research process because I just have a different perspective because I'm not the one writing the research papers, but I spend a lot of time reading them. And we live in a time when I think it might be shifting a little bit. So this is a little bias on my part. Medical doctors have a little bit more leeway because of their authority to say things, even if they don't have the research to back it up.
Yep.
There I said it.
I think that's a fair statement.
And it irritates me, right? Without the MD on my name, everything I say is under the microscope. So I have taken almost insane, like almost clinically insane, like level approach to the research, because since I don't have the letters beside my name to just say whatever I want, not that everybody does that. I'm sorry if it's offensive, but I'm saying it. Anyways, the point that I'm making, though, is that we live in a time where we do need to have that research to back up what we say, at least in some situations. But it can lead people to think that research is infallible, and it can prevent people from really looking critically at this whole concept of research and publishing and journals. And, it is not objective and it is a publishing process. And so certain ideas are published and certain ideas are not published. So I really appreciate you sharing that even for the research that you're doing, it's not just straightforward. You just write this great paper and it's just approved. Like you're having to submit it. And I'm sure it's common for everybody in the field, but I'm just saying that
Yeah.
is very, very telling.
Yeah, and let me just share, like, I'll share a story. So, I think one of the research articles that I am most proud of is the article that Dr. Stanford, Dr. Prusnick, and Dr. Vihil and I published in 2022. And it's the overview. It's fertility awareness-based methods for women's health and family planning. And we did a comprehensive review of the literature. There's over 100 citations in this paper where we were looking at the role of fertility awareness-based methods in women's health, its effectiveness in preventing pregnancy, as well as its effectiveness in achieving pregnancy. And because I felt this article was so important and that many doctors needed access to this information, I submitted a proposal to have it published in the American Family Physician Journal. Now, again, full disclosure, this is the journal that my husband is the associate deputy editor for. So I went through the proper channels so it would bypass him and just go right to the editor in chief for consideration. And the American Family Physician Journal is actually the most widely read medical journal in circulation. I mean, New England Journal of Medicine and JAMA there's more subscriptions, but more people actually read the American Family Physician Journal, which matters. I mean, we can write things, but we need people to read them. When the proposal got to the editor-in-chief's desk, they wouldn't even consider it. I was like they were like, don't even bother submitting. I was really upset and angry, as you could imagine. And I understand now, their criteria are different from what I was proposing. Like it just doesn't fit the criteria. But at the time, it really felt pretty terrible. And we ended up submitting that paper to like 2 to 3 different journals. Now, I was able to work on that paper as part of my fellowship. But I think the other thing that's important for people to be aware of and your listeners to know is that research takes money and a lot of money. And as you know, Lisa, in the field of fertility awareness, there's not a lot of money in the field of fertility awareness. I mean, people aren't going to make a lot of money teaching women how to chart their basal body temperature. I mean, now we're seeing an influx of cash and an influx of funding due to the technology. But, looking at the traditional methods for charting, Billings, Creighton, couple to couple leak, SymptoPro, all of these methods that are paper-based, there's not a lot of money to be made. And so there's not a lot of money to do the research and to get the research published. And as one of my colleagues, and again, another tremendous mentor to me, Dr. Phil Boyle, who is a family physician in Ireland, and he's the founder of Neofertility, he likes to say, just because it isn't published doesn't mean it isn't done or that we don't know the information. And that's the challenge, because somebody like Dr. Boyle, who's primarily a family physician in clinical practice, he sees the results in his patient population, but then trying to get that data published is really, really hard. And it's even harder when it goes against mainstream medicine. So I know for a fact that Dr. Boyle and colleagues have a paper that's been rejected multiple times because it looks at a comparison of the effect of restorative reproductive medicine treatments in the treatment of infertility versus IVF. And the reality is the success rates with RRM are much higher and the cost savings to the healthcare system is much greater. And yet, because of it does not shine a positive light on the conventional IVF industry, he's had a very difficult time in getting that paper published. So the research has been done, but it hasn't been published. But even doing the research, and again, like Dr. Stanford, he's developed a project called STORM, Surveillance, Treatment, Outcomes, and Restorative Reproductive Medicine. Like, let's look at the treatment, let's survey the treatments we're offering. What are the outcomes? Is it improving fertility rates? Is it reducing the miscarriage rate? Is it improving women's health overall? But there's a need for more funding. And I know that sounds pretty pessimistic, but there is some optimism to be had. And I'm happy to share about that next, but let me give you just a chance to comment on some of that.
Yeah, like you said before, I just really appreciate you shedding some light on that because, I mean, like everything you said, it doesn't surprise me one little bit, right? Because that's what we're dealing with. But I think for a lot of people who haven't necessarily immersed themselves deep into the research rabbit hole or even contemplating
what if I did want to publish a paper? What would have to happen? And like thinking about all the barriers to that becoming a reality. We really need to understand. So I love research. I love having access to these studies. I think that it's essential to moving forward in this field. And, as do you, based on everything you said, right? But I think that we have to remember that this is an establishment, and they are putting forward a certain ideology and they are publishing based on that. And so what you see, and it's incredible how much research is published. I would love to know a number of how many papers get published every day or every year, like with all the different journals. It's just massive. The amount of knowledge and data that does get published is just mind blowing, right? But then imagine how much isn't.
Yeah.
And there you go. So I think we needed to have that little piece of the discussion so that people really understand, like when people say, oh, you don't have any evidence for this and you don't have evidence for that and everything like that, that might be true. But like you said, just because it isn't published doesn't mean it isn't there.
Right.
And just because it hasn't been put in a specific journal doesn't mean it isn't true.
Right.
And this makes it a little bit more gray. Like it would be better if we had research for everything, but there are solid barriers for that right now.
Real Food for Fertility is your ultimate guide to optimizing your nutritional stores before pregnancy. In Real Food for Fertility, my co-author Lily Nichols and I argue that a healthy menstrual cycle sets the stage for optimal fertility and a healthy pregnancy. You can read the first chapter for free over at realfoodforfertility.com. And did you know that you can listen to Real Food for Fertility for free when you sign up for a 30-day trial with Audible? Head over to fertilityfriday.com/realfood, one word, for details. That's fertilityfriday.com/realfood. Now let's go ahead and jump into today's episode.
And it's funny because you mentioned it's a little more gray. There is actually something that we refer to as the gray literature. And this is the evidence that it is circulating in the mainstream medical community. Maybe it was a research study that was presented at a medical conference. So the data exists in the conference proceedings, but it hasn't been published. So yes, there is research that is out there, but the reality is we need more. I mean, when I decided, people are like, why are you moving from like the East Coast to like the middle of Mountain West, to Salt Lake City, Utah? I said, because at the time, Joe Stanford was the head of the Office of Cooperative Reproductive Health at the University of Utah. It was the only office or center or institute at any medical school focused on fertility awareness research. Dr. Richard Faring is a PhD in nursing. He had founded the Marquette Institute of Natural Family Planning at Marquette University, but that was it. So there's not a lot of money or resources or institutional support that's being dedicated to that. But the good news is because of the work that I have done with facts about fertility and in educating the medical community and in building a research database, that actually brought me to the attention of the dean at Duquesne University's College of Osteopathic Medicine. Duquesne University is a university in Pittsburgh, Pennsylvania, founded over 100 years ago. But just last summer, in July of 2024, Duquesne launched a new College of Osteopathic Medicine to train osteopathic physicians in the care of the whole patient. That's not anything like new and exciting. I mean, there are new colleges of osteopathic medicine opening up all over the United States. But what was unique, when they launched the new medical school, they also launched a Center for Fertility Awareness Education and Research. And I'm proud to say and excited to say that I was hired as the first director of this new Center for Fertility Awareness Education and Research in an effort to integrate education about fertility awareness-based methods into mainstream medical education, and also to build a research database and get more research published, it's so critically important that we do this research. But the reality is we need more funding. We need more people that are trained to do research, and we need more support from the system as a whole. And, the irony is I got to spend an entire day teaching all of the first year medical students at Duquesne about the female cycle and how to read female cycle charts. And it was amazing. Of course, it was November 2nd, 2024, which I know you're from Canada, so you may not appreciate the significance of that day, but it was the day after the election here in the United States. And I thought, wow, this is the day I get to teach. Like, this should be interesting. But as you know, Lisa, the way I approach this topic is I'm focused on sharing the science, right? This is not about a political ideology. This is not about a person's faith. This is about the way the human body is designed to work. And so my focus has always been on sharing the science underlying the health of the female cycle. And regardless of a person's political leanings, I think the outcome in the United States does have the potential to lead for more funding and support for this effort, because there is a push now to focus on nutrition, to focus on sleep, to focus on restoring the body to the way that it's designed to function. And as you know, at FACS, we focus a lot on many aspects of women's health and fertility. And our 2025 conference theme is New Horizons in Holistic Women's Health, because when I was trained as a medical student, if a patient presented with PCOS, first line treatment was put them on the birth control pill. The reality is I know now that actually is not the best treatment. In fact, can worsen the underlying condition, because with PCOS, it's a metabolic disorder, and very commonly insulin resistance is a main contributing factor. So you really do need to focus on nutrition. And, that's something that I think could become a focus of the Department of Health and Human Services within the United States government, and potentially lead to more funding for folks to take a more holistic, a more comprehensive approach to really empowering women with knowledge about their body and educating physicians to diagnose and treat those underlying root causes, leading both men and women to have healthier reproductive function. So super excited about the potential.
Mm-hmm. Okay, we need to take a minute to just hover over the fact that Duquesne University decided to do this new medical school and opened a Center for Fertility Awareness Research. We just need to because I was doing a little party dance, happy dance when you mentioned that, and I was like, how did that happen? Like, this is what dreams are made of, at least in my community.
Exactly. And I will say, it happened because of a gift from a family, a family that was like, we want our family members to have access to this kind of care. And the reality is that access to, physicians and other medical professionals trained in fertility awareness and restorative reproductive medicine is still really, really hard for many people to be able to achieve. And so this family, through their generosity, decided to make this very generous gift to be able to train the next generation of medical students at Duquesne in these methods, and to fund the research so that doctors from around, Pittsburgh and Pennsylvania and the United States and the world can have access to standardized restorative reproductive medical protocols, for example. And I'm excited because just in January, two big things. We applied for a grant through Duquesne to help with developing standardized protocols. But from a FACS perspective, I'm super excited about this, Lisa. We actually contracted with a woman who's a professional research librarian to help us build a database of research articles related to fertility awareness and restorative reproductive medicine, to make that available to members of the FACS community, which we're really, really excited again about all of the opportunities that seem to be coming up. And I think it will be for the better of the health, again, of women and men.
Well, and I have one more comment on this kind of like topic here. Like, we've talked about so many different things, but ultimately this change is coming because individuals like yourself, like myself, and like that family are deciding that this is important and taking action. So, I feel like there's always this question of how do we get this into schools, and how do we, I don't know who you're waiting for, because it's you, whoever needed to hear that today. Like, it's not just going to happen.
Yeah.
We were just talking a little bit about and you've mentioned a couple of times, like when I first started, like, had you not started FACS, had you not made a big stink about it, for like over a decade. How long have you been working at this, right? Had you not been doing that, this opportunity would not have fallen into your lap, right? So it feels so serendipitous, I'm sure. And we can pretend like it just magically happened out of the blue, but it's a result of you making a stink for a very long time. And so congratulations. This is all wonderful. And I'm so excited to be able to celebrate with you at, this is like fertility awareness is growing up. Oh my gosh. It's like going to your first school day, like going to university, like fertility awareness is like going off to college, right?
Yeah. It's so funny you say that. And I love being able to celebrate with you. And I just want to like celebrate your 10-year milestone last year. That's amazing. I know I've been on your podcast quite a bit, but it's awesome to see how much this podcast has grown up. But yeah, when Facts became our own nonprofit and we left the FMEC, I tell people, I felt like I was graduated from college and now I'm moving out of my parents' house and I live in an apartment and like some days I have money to pay rent, some days I have money to buy food. Some days I have money to do both, but to your point, it really does depend on individuals. I mean, yes, this family gave a significant gift to Duquesne University, but Facts itself, we subsist in large part on the support of our donors. I mean, in 2025, our goal is to recruit 25 donors that will give Facts $25 a month. So it's not a lot, but it really does make a difference. I mean, to your point, I started Facts in 2010 and it was fully volunteer until like 2016, 2017, when I was able to small grant here, a little bit of funding here. My sister, who's a trauma critical care surgeon, I mean, she single-handedly supported Facts for the first 2 to 3 years we had employee or contractors because, again, there's no money to be made in this. I joke when I give presentations and I have my disclosure statement, I'm like, I wish I could say pharmaceutical companies were giving me tons of money, but the reality is what I'm presenting is going to cause them to potentially lose a lot of money. So we're not getting support there. But, the support of people that, that donate to Facts, which is a nonprofit in the United States, it really does make a difference. And it does allow us to train more doctors to help more women and more couples really achieve their reproductive health and their family planning goals. So yeah, if you're a listener, even just sharing a podcast, I mean, it doesn't necessarily even mean making a donation. Sometimes it means just helping somebody else to learn the information. And I should say, I mentioned we hired a research librarian or contracted with a research librarian. We finally reached the point towards the end of last year where we were able to hire a full-time development coordinator to help us really grow the Facts community. And that's been instrumental. And that's what's allowed us to expand to now have an elective for residents. Now we're getting into nursing schools. And there are more medical schools that are opening up and reaching out to me and saying, how do we integrate this into our medical school in Kansas? How do we integrate this into our medical school in Ohio? So it's really exciting to see the change happen. But I would be remiss to not acknowledge all of the people that have worked with Facts, many volunteering, many who have just given of their time, and our donors. I mean, it's really been incredible to the success of the work that we do. And so I'm so grateful.
And you never know who's listening. So yes. And I'll share, of course, we'll have all the links and all the information for anyone who's listening on the show notes page. Okay. So we actually, interestingly, we're going to talk a little bit about miscarriage today. I'm glad that we did take some time to do some updates because that was lovely just to kind of talk through some of the exciting things that are happening for you and for Facts and for fertility awareness, the field overall. So that's really, really exciting. So I want to shift and talk a little bit about miscarriage. When we were having our pre-chat, you started by asking me if I had a miscarriage because miscarriage is so common that as soon as you start talking about miscarriage, I've always kind of said that it's like, it just comes out of the woodwork. And, it wasn't until I had an early miscarriage before I had my first son and I talked about it that at least like everyone I knew, like as soon as I mentioned it, this girlfriend's like, oh, I had one. Oh, I had four. And like, you never told me. I had no idea.
Right.
So let's talk a little bit about, you could share whatever you want to share about the stats and how common it is, but also some of the research that you've been doing in this area and the implications.
Yeah. Yeah, no, absolutely. And yes, as you noted, miscarriage is so common and yet it's also a secret. So many women keep it a secret. And part of it's like the way we approach pregnancy. So many women are encouraged like, oh, don't tell anybody you're pregnant until you're 12 weeks and you're sure it's going to stick, right? I mean, regardless of whether or not the pregnancy continues or you lose the pregnancy, once you're pregnant, I mean, it has a huge impact on you physically, emotionally, socially, as you begin your journey to motherhood. And yes, I mean, people experience miscarriages at different phases, and it may impact women differently. But the bottom line is it impacts many, many, many women. And, as a physician, we learn the statistic like, oh, miscarriage happens about 15 to 20% of the time. So that may not seem like a lot, like 1 in 5, 1 in 6, right? But when I teach my medical students, I ask them to think about like, well, what is it 15 to 20% up? What is the denominator? What is the actual number of miscarriages, right? And in the United States of America, the most recent data that I've looked at from 2022 showed it's 15 to 20% of live births, right? So in the United States of America in 2022, there were 3.6 million live births, which means if you're looking at 15 to 20%, you're looking about 540 to, can't do the math, I had 720,000 miscarriages, 500,000 to 3 million miscarriages. There's some statistics that say in the United States, there's up to 1 million miscarriages that occur. Now, I don't know what it's like in Canada, but in the United States, we do not actually track miscarriage as a cause of death. And I don't want to get into the politics, like what is death, right? But the reality is that from embryological development, we know that the human heart begins to form and begins to beat at about 3 weeks post-fertilization, which translates into about 5 weeks along in the pregnancy, right? And when we look at miscarriage rates, we're looking at miscarriage rates between 5 to 12 weeks, right? So if you have about 1 million miscarriages, women losing a baby after 5 weeks, if we actually did count that as a cause of death, in the United States of America, if we counted miscarriage as a cause of death, it would be the third leading cause of death in the United States of America after heart disease and cancer, right? Now, in the United States, February is Heart Disease Awareness Month. I can't turn on a television, open up a newspaper without seeing something about like Heart Disease Awareness Month and what can you do to prevent heart disease? Same thing with like cancer. There's all of these initiatives and programs and foundations, prevent breast cancer, prevent colon cancer. That is all good, and we should be focusing on that. I'm a family physician. Prevention is core to what I do. But we need to look at that with miscarriage. If it's the third leading cause of death, what are we doing to prevent it? And the reality is the way we're conventionally trained in medicine is that miscarriage happens, it's common. We don't begin to even look into the underlying causes of miscarriage until a woman has had at least 2 or 3 miscarriages. Now, Lisa, I know you're a mom of 3, beautiful children here on this earth. And would you say, well, I'm not going to try and figure out like if my child's life is ending, prematurely, I'm not going to look at that with my other children until like I've lost 2 or 3 of them. No, we wouldn't even think to that. And so my goal as a family physician with additional training in restorative reproductive medicine is to prevent miscarriage. And so tying this back to the research, when I did my research fellowship with Dr. Stanford at the University of Utah, I chose to study miscarriage. And my specific question was, does a short luteal phase increase the risk of miscarriage? And I'm glad that I did study this topic because personally, everybody is affected by miscarriage, whether they themselves have had a miscarriage or somebody in their family or friend. Everybody knows somebody that has miscarriage. And I just want to pause here, for your listeners to say that although you may not have experienced being seen in that miscarriage, I just want to acknowledge your loss and let you know that I see you in this. And my heart goes out to you. My condolences to you. I've had patients that have lost 1 or 2, pregnancies or babies to miscarriage. I've had patients that have lost 8 to 10. And it doesn't matter whether it's 1 or 10, each one matters and each one really does make a difference. So I wanted to just take a minute to pause and to recognize that, because for many of these women, as you alluded to, many of them may be living in silence because they haven't shared because, although miscarriage is common, we're often discouraged from speaking about it. And I think women should be encouraged to say as much or as little as they want, but we should create an open environment for them to share so we can help, not only help them in the recovery process, but work with them to see, are there underlying risk factors that we can identify and address.
I wanted to pop in with a quick message from today's sponsor, Audible. Did you know that you can listen to The Fifth Vital Sign for free when you sign up for a 30-day trial with Audible? Head over to fertilityfriday.com/audible for details. That's fertilityfriday.com/audible. Now let's jump back into today's episode.
Absolutely. I appreciate you for saying that. I think women's experience of miscarriage is so varied. And even when I was sharing about my own experience with miscarriage, which was at the 5-week mark, I've often felt that kind of tendency to downplay my own experience, because I know that there are women out there who've had later term miscarriages, stillbirths, multiple losses. And I think that we all have a tendency to do that. And even some women who have experienced multiple losses might even say something like, well, but my friend had it worse than me. So I think it is really important for us to acknowledge our own losses and take the time for that. It's very interesting to hear you put miscarriage into a different perspective, comparing it to the kind of all-cause mortality rates or specific causes, to find that it would be the third leading cause of death. I think that that's a really interesting perspective, but it really shows how far-reaching this issue is, and it gives you some insight as to how many women are affected by this. Yet, to your point, we don't talk about it at all.
Mm-hmm. Yeah.
So did you want to talk just a bit about, like, there's so many different ways I could approach it, but you mentioned that, which is kind of common knowledge in my world, that typically, unless a woman has experienced like 3 miscarriages, the doctors don't even talk about it. So do you want to talk a little bit about that and what you found in your research that can, it's a big question that could reduce the risk of miscarriage?
Yeah, I definitely want to talk about it. I think when we look at miscarriage and the risks for miscarriage, I think we need to talk a little bit about the elephant in the room. The most significant risk for miscarriage is the age of the mother, right? And some would argue, well, is age a modifiable risk factor? I mean, I am the age I am. I can't turn back the clock and be 10 or 15 years younger. So, it's not modifiable from that sense. But could we modify how we educate and encourage and support families to have children? I mean, in the United States, there's such a push for people to really establish themselves in their professional careers and put off and delay having a family until like later. And oftentimes, this is when a woman is after 35, after 40, and the risk of miscarriage goes up dramatically, really starting around 35. And so the more that we can do to create a system where it's easier for people, if they so choose, to have children at a younger age. I work with a lot of female medical students, right? And they ask the question, like, when's the best time to have a baby? I'm like, when you're ready. There is no best time. At our 2025 FACS conference, one of our keynote speakers is Dr. Anita Showalter, who is my boss at Duquesne. She is the division chief of specialty medicine, and she's an OBGYN. And the topic of her talk is having it all, but not all at once. And she's going to share her story, how she actually got married as a teenager and started having children in her 20s and had 4 children before going to medical school and becoming an OB and now becoming division chief. So you can still achieve your goals. And so I want to just acknowledge age as really one of the most important risk factors. Now, to the question as to why, I get this question a lot, like, why don't doctors look into the cause of miscarriage? Why don't they do anything about it until a woman has had 2 or 3 miscarriages? Part of the reason is that the research shows, and this is old research, to be clear, like this is an area where we really do need more study. But from old data, the research shows that about 50% of the miscarriages are due to genetic abnormalities with the embryo, right? And so if there's, a genetic mismatch, it's very unlikely that there's going to be anything that we can do to fix that. But the reality is if 50% are due to genetic, that means 50% are due to other factors. So 1 in 2 times, there are factors that we can change. Some of these may be anatomic factors, like women with a bicornuate uterus, or fibroids. Some may be due to hormonal issues, low progesterone, low estradiol, things like that. Some may be due to other underlying diseases like diabetes and thyroid disease. Some can be due to environmental factors. So there's so many factors that can affect a woman's ability to carry to term. And if a woman is having multiple miscarriages, it often reflects less an issue with the particular embryo, but more likely an issue with maternal health or anatomy or environment. And these are things that we really need to look to address. I didn't share this with you in the pre-chat, but on yesterday morning, I got a text from a patient with 4 beautiful pictures of her baby girl that she had after seeking care with me after having had 3 miscarriages. And in her case, like in many of my patients, it's oftentimes underlying hormonal issues. So I'm regularly using progesterone to support the luteal phase and to support the pregnancy. There was a research article that was published about a year ago by Dr. Phil Boyle demonstrating the importance of estradiol, right? We often think of progesterone as important in pregnancy, but in this study, Dr. Boyle found that in women with normal progesterone, if their estradiol was low, their miscarriage rate was 45%, right? 1 in 2 experienced miscarriage, 3 times the normal, the average rate. And so he found that in giving estradiol, the miscarriage rate was reduced to 21%, which is great. It dropped by almost half. But the reality is this estradiol can increase your risk for blood clots, and there's other risks. So instead, he started giving women DHEA, which is a hormone that the body uses a building block to make estradiol. And in that population, the miscarriage rate dropped to 17%. So it dropped it back down into that normal range. Another hormonal issue, and I think this is an important one because I tell my family medicine colleagues, we really play an important role in this, is thyroid, right? Thyroid hormone is so critical to overall metabolic health, and it's especially important in early pregnancy when we're basically growing a new human being. According to most labs, a normal TSH or thyroid stimulating hormone, which is the test that we most often use to screen for thyroid disease, the normal values according to traditional labs is anywhere between 0.5 and 4.5 or 5. But there's research from the American Society of Reproductive Medicine that shows women with a TSH greater than 2.5, which is right smack dab in the middle of that normal range, women with a TSH greater than 2.5 have a higher, statistically significant, higher rate of miscarriage and infertility. So we do need to be more aggressive at identifying and treating thyroid. So when I get a new patient and she says like, oh, I had my thyroid checked and it was normal. I'm like, what was the lab and what was the value? Because it may have been normal according to normal lab standards, but if it's higher than 2.5, you may still be at a higher risk. And, I have a patient who had a terrible miscarriage and terrible postpartum or post-miscarriage depression, and she was able to conceive within 6 months because we addressed her underlying thyroid issues.
Mm-hmm. Well, so a practical question, and there's no perfect answer, obviously, but for a woman who has had a miscarriage or more than one, and maybe has attempted to approach her physician and hasn't been well received or has been kind of pushed off, what, if anything, would you want her to know in terms of an approach to get answers or to find the right provider that might be willing to help her to look deeper?
Yeah, great question. And I'm going to pause here because you said the word provider, which is a trigger word for me.
Okay.
Like nails on a chalkboard. And I'll share, I like to refer to physicians, nurse practitioners, midwives as medical professionals, because as a provider, the idea is like, you're the customer, I'm the provider, you want this test, I'm going to provide it because you know what's right. And the reality is that we're professionals and we have to make the decision, right? What is actually in your best interest? Now, the challenge is most medical professionals don't know what testing they need to order. There's some testing, but again, many doctors won't even look at that until a woman has had 3 miscarriages. And so one of the things, like I said, we just applied for grant funding, and one of the areas we're going to focus on is developing standardized protocols for how to evaluate women and their risk for miscarriage and what we can do to reduce that risk of miscarriage. So fingers crossed, the grant will come through, and by the end of 2025, we will have, protocols on that. But what I would want them to know now, or where I would encourage them to look for research, is on our factsaboutfertility.org website. And I am thinking about the need to put together like topic areas, right? Like all of our blogs on miscarriage. We have written about Dr. Boyle's article. We have written about thyroid. I've had patients, I had a student, a medical student who had taken our elective, who had a history of hypothyroidism, who got pregnant, went, called her doctor and they're like, oh, we'll check your labs, at the end of your first trimester. And she messaged me. She's like, I'm like, needs to be done soon. I'm like, absolutely. And there's a great article tying it back to the American Family Physician Journal, AFP. I encourage your readers to go in the American Family Physician Journal. There's a great article on thyroid disease in pregnancy. And what they state, and this is according to the research articles, women who have a history of hypothyroidism, who are on levothyroxine, if they have a positive pregnancy test, they should increase their weekly dose of their levothyroxine by 5 to 10% of that weekly dose. And so if you have thyroid disease, find this article, print it out, bring it to your physician, your midwife, your medical professional, and share this information. I mean, you know this, Lisa, you said you love research. There's gazillions of articles out there. It's hard for us doctors to keep up with it. And I'll be honest, it drives me crazy when patients come and say like, well, I saw this on Google. I'm like, but what's the source? So if you can go to, the source and have a research article, and Lisa, I'm going to share these research articles with you specifically, so you can include links to them in the show notes so that people don't even need to leave your website. I mean, we encourage them to visit our factsaboutfertility.org website, but you'll have it for them there so they can share the science and raise the question about what should be done to minimize their risk of miscarriage.
Mm-hmm. Yeah, no, I really appreciate that. And it is always tricky to navigate this conversation between you and your doctor. And as you said, it's the trigger word for doctors would be, and I did my research, because it just really throws off that power dynamic. But at the end of the day, when you go and see your doctor, you and the doctor are in the sandbox and you have to figure out how you're going to play nicely. Yep. And we hope that your doctor will be open and respectful. And ultimately, what I always say is like, if you went to a hairdresser and the hairdresser, you're like, I think I want to try a new color. And your hairdresser was laughing at you and like, that's such a dumb idea. Why would you want to do that? You wouldn't actually continue to pay this person money or let them anywhere near to your hair. So I think we should take the same approach. Not that we're like, I think we always need to be respectful or else you're not going to get anywhere.
Yeah.
But at the same time, I think we do have to take the onus of finding the doctor, the medical health practitioner who is going to take you seriously and actually just hear you out, just have a conversation. Like it's supposed to be like two ways, right?
Shared decision making, I like to call it, right? Yeah. And to be clear, like it never bothers me when a patient comes in and says, I did my research, because there are so many areas where I am not well versed. I mean, like I mentioned, in medical school, we learn next to nothing about nutrition and how important it is in health, which is crazy because like good nutrition is fundamental for overall health. So when patients do research, I'm like, what did you find? Let me see what you have. And I appreciate it because I'm like, oh, you saved me the trouble of having to do the search myself on PubMed. So I do appreciate that, especially when they're coming in with the scientific articles. That does make my life much, much easier. But it is a difficult dynamic, right? Because there is that power differential, right? And so I want to encourage your listeners. I am always happy to talk to fellow medical professionals. I'll share a story. Last year, one of our FACT speakers, she reached out to me because she had a client who had miscarriages and was pregnant again. And she's like, can you see her? And I'm like, she lived in a state where I'm not licensed. I'm like, well, I can't officially see her, but I'm happy to have a conversation with her. And I did. I had a conversation. There were definitely some things that suggested some underlying hormonal issues. And she was actually seeing a Creighton medical consultant. She felt like, they weren't really looking beyond progesterone. And I was like, well, they need to look at this. They need to look at this. I mentioned Dr. Boyle's article. I said, and you know what? I'm happy to have a conversation with your medical professional. Here's my number. Feel free to connect them. And I'll give you the fax number. Anybody can reach one of my fax colleagues. And the messages will get back to me is 240-80-FACTS, FACTS. So whatever those numbers are, I think it's like 32 something, but we can share that in the link too. Or they can email info@factsaboutfertility.org and say like, would you connect with my medical professional? I love to teach my colleagues. And the reality is most doctors, they do want to help patients. It's just so hard when there's so much to learn and there's so much to keep up with. So if there's a glimmer of like, you think openness and you're like, if you'd like to talk with another doctor, who's an expert in this field, like I would be happy to get you connected. I think it's so, so, so important that we share this information. And I want to support patients. I can't see every patient. That's a reality. I'm running facts. I do have a small practice. I've been full for years, but I do want to help patients get the care they need. And if that means connecting them with a doctor in their community or via telemedicine that can help address those underlying issues that may be leading to increased risk of miscarriage or infertility or even painful periods in your teenage daughter, whatever it is, at FACS, we want to help. And we do have a physician clinician educator directory, but we really need to build it up. I want to make sure you're on that directory too, Lisa. And we do need to expand the directory, but always happy to help people connect them with the medical care that they need and that they deserve.
Mm-hmm. Yeah, I mean, I don't know, rewind and just re-listen to that part. As we start wrapping up, I mean, you've shared such a wealth of information with us today, and it's been just such a treat having you on the show. I suppose let us know if you like all the places where everyone can find you and what you have coming up that's new and exciting for the year that everyone can know about.
Yeah, absolutely. I mean, again, we encourage people to visit our factsaboutfertility.org website. Our in-person conferences, we're now doing those at the beginning of the year. But we will do a virtual conference in the fall. Not sure exactly yet the date, but we'll make sure but if we know that by the time this comes out, we'll put it in the show notes. So check the show notes. But if you don't want to wait, we do have an online continuing medical education course. It is now approved through the American Academy of Family Physicians for 13 parts. Each one is worth 16 CME credits. And while the content is geared towards medical professionals, anyone is welcome to register to participate in any of the live case study sessions or watch the recordings and read the research articles. We do have a number of sessions on miscarriage and recurrent pregnancy loss. So visit the factsaboutfertility.org website under Learn More and enroll in our CME. And again, you do not need to be a doctor or a medical professional to enroll. We do want to make it more widely available. And if you want to email us at info@factsaboutfertility.org. And if we can help you get the care that you need and deserve or connect you with the medical professionals that can provide that comprehensive restorative reproductive health care, we are happy to do so.
Wonderful. Well, we will make sure to include all the links and everything that we mentioned in the show notes. And I just want to thank you again for being here.
Thank you, Lisa. It's always a joy.
Thank you for listening. If you enjoyed today's show, please share it with a friend. You'll find the show notes page for today's episode over at fertilityfriday.com/568. I hope that you enjoyed today's episode with Dr. Duane. We covered two really important topics. As I mentioned at the top of the episode, I just think it was such a great opportunity to dive into this topic of research and really getting into some of those politics, like which papers are published, which papers are not, why not? Who has the money to fund research, so that we're not looking at the field of research as this infallible thing where, everything we want to know has already been studied. It's just not true. When I dive deep into the research weeds, it doesn't take me long to find a lot of different areas that it's very hard to find research on. And one of the questions that I often say, and I'm sure I've said it on the podcast many times, is like, who's paying for it? So I could think of several examples. There's inconclusive, at times, research on withdrawal as a method of birth control, because there's some studies that show that none of the men had semen in the pre-ejaculatory fluid, which would be the whole thing, which would that's the piece of information that we're curious about. Do men have semen in their pre-ejaculate? Because if yes, then that could mean that this method couldn't work. If no, then it could mean that it is a legit method. And it could explain why withdrawal does have a pretty decent effectiveness rate when used perfectly. So again, withdrawal is controversial. But what I always say is that, let me backtrack a little bit. The research that I share in the Fifth Vital Sign and Real Food for Fertility that we talk about in the FAM program often does have really small sample sizes. And so you can take some insight from those studies, but ultimately it's not giving you this really confident, conclusive answer. And they're not in depth enough to provide even an explanation as to why theoretically there should be no semen in the pre-ejaculate, and there is in some men, and there's just not enough data in the study. I want to know, what is your explanation as to why it is there, given that based on the literal biological structure of the male reproductive system, it shouldn't be there. So anyways, I know this is a bit of a tangent, but I'm making a point. When something like this comes up, the question that I often ask is, well, who's paying for this? There's no money in a method of birth control that you can literally just do without buying anything. There's like, who is paying for this research? Who is funding it? And so sometimes when it comes to topics like this, where it would be so interesting to get a more in-depth research study and answer about something like this, you have to think about it. You have to understand the nuances of the industry to recognize that, there's not a lot of motivation to get this result. The drug companies make billions, hundreds of billions of dollars. So if they just say, oh, this is a super effective method that you could do at home with absolutely no payment to anybody, right? Maybe they're not going to publish that. And maybe they're not going to find the funding to do it, because who's funding it? There's no financial benefit here. And I often say that when I'm looking for specific fertility data or women's reproductive health data or menstrual cycle data, it's often in the IVF research that we get some of those answers, because again, where is the money? So if you're trying to find research on something, you often have to think about it that way. Where's the money? How am I going to find the research? Well, there has to be a company or an industry that's going to benefit from doing this study, who actually financially benefit, who would then be motivated to actually do it. And often that's where I found a lot of interesting research on various topics, because that's where the money is. So like I said, this conversation with Dr. Duane, I think was really, really insightful, and I'm really glad that I got to share it with you. Of course, the discussion that we had about miscarriage is equally important. It's an incredible topic. It's an incredibly sad topic, but it's an incredibly interesting topic when you get into it, especially because many women who experience miscarriage often think that, it's something that only they have experienced, until they speak to anybody, friends, family, strangers, and you just realize how common it is. Miscarriage is extremely common. And even in the research, when we look at the prevalence, it is extremely common. An average of 1 out of every 5 pregnancies ends in miscarriage. And that changes with age. As we get older, a higher percentage of pregnancies end in miscarriage due to just some of the complications related to aging and increased instance of chromosomal abnormalities and oxidative damage to, DNA and that kind of thing. So there's a lot of reasons for that. But again, there's a whole lot to be said about this topic, and there's a lot more education that can be done. And theoretically, there's, a lot of miscarriages could be prevented with proper education, information, even proper planning. Doesn't mean every one could be prevented. I think there's a lot about it that we don't know, but obviously a really important topic. And I was really happy to have Dr. Duane here today to talk about both of these issues. So if you enjoyed today's episode and you can think of someone who would benefit from hearing it, the share link is fertilityfriday.com/568. And with that said, I hope you have a wonderful weekend, whenever you're tuning into the show. And of course, as always, until next time, be well and happy charting. If you enjoyed today's episode, you're going to love our top resource for women's health professionals, How to Interpret Virtually Any Chart Your Client Throws at You. Our newest ebook breaks down complex chart interpretation into an easy step-by-step process. Head over to fertilityfriday.com/chart to snag your complimentary copy today. That's fertilityfriday.com/chart.